Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar. That is on very important topic. That is from urine to urothelial cancer, a smoker's case of gross hematuria. For this topic, we have very eminent and important speaker. He is none other than Dr. Mahesh Desai, sir. And let me share some of the achievement of sir. Sir has done MBBS, MS, FRCS from London, FRCS from Edinburgh, and he is head of robotic surgery and medical director at Moijibai Patel Urological Hospital, Nadiad. So, by taking not much time, I would like to invite sir. Sir, the stage is yours. You can proceed from here.
Thank you. Thank you so much for invitation. And you have chosen a topic which is very, very important. Um, um, urine to urothelial cancer, a smoker case of gross hematuria. Um, so, um, I bring the greetings from Nadiad, Gujarat, and the general public in India is ill-informed of the association between the cigarette smoking and tobacco chewing and the bladder cancer. But in Europe, there is a decline mortality from the bladder cancer in Europe because of the favorable trend in men due to a decline in smoking and reduced occupational exposure to the occupational carcinogen. But in women, it's difficult to explain, but I feel that the hair dye is the one which is responsible, can be responsible for a bladder tumor. And then the lesser extent, a UTI. Now, how do we present if you are a smoker and you are an active smoker, but if suppose in the family somebody is actively smoking and you are staying with it, you may be a passive smoker. And then chances on a long term, you may get a bladder cancer. Symptoms would be a passing of blood in the urine, which is known as a hematuria. Now, hematuria can be initial, it could be total or a terminal. The presence of a blood clot in the urine, it could be painless or painful depending upon associated urinary infection. And if you do the urine examination, there would be red blood cells, and then you suspect the bladder cancer. And then the first screening test you do is the cytology and ultrasound of the full bladder. Now, if you have a blood in the urine, if it is initial, it could be because of the urethral stone or a bladder stone, or it may be total hematuria, right? From the beginning to the end, it may be a kidney stone or a kidney tumor. While if it is a total but also terminal, it could be a bladder tumor, and that if the tumor is near the trigon, it could be a terminal hematuria. Now, of course, you have a cancer of the penis, then it can have a bleeding per urethra anytime. So first thing you do is the urine cytology, and the urine cytology is more sensitive in detecting the high grade urothelial carcinoma than low grade. The sensitivity is a 10 to 43% for the low grade and 50 to 85 for the high grade, while specificity is 26 to 88% depending upon the type of the urine sample. The rate of malignancy in the urine cytology is 1.7 to 5.8%. But there are some diagnostic criteria when you examine the urine. At least there should be 5 to 10 abnormal cells, the high nuclear to cytoplasm ratio, moderate to severe hypochromic nuclei. And this is all the pathologists would diagnose: marked irregular nuclear membrane, coarse and dumped chromatin. Now, this is the urine sample, and here you can see the normal cell with a normal nucleus. But if you have an abnormal cell with a large nuclei, this is atypical. Atypical urothelial cell, chances of malignancy is there. And there are lots of RBCs and the cells in the urine. Now, if you this is a high power, you will be able to identify a large nuclei and less cytoplasm. This is a typical urothelial cell. It is against this normal where you have a more cytoplasm and small nuclei and normal epithelial cell. So this should give you a suspicion of a malignancy. And this is a pap scan, again, you can see the atypical urothelial cell and the normal urothelium can be differentiated. And that will give you the idea that there is a chance that there may be a papillary tumor. But then there are so many. If the patient is a smoker, he should make sure that he should have the urine test. An early result of the bladder cancer screening in a high risk population of a heavy smoker is the urine test. There is a dipstick cytology, NMP22 bladder check, BTS stat, Eurovision or a fish examination, immunocyst. All of these are urine tests, which is a screening. You can give a urine and then you can get a result and you can suspect there is a bladder cancer. Now, NMP22 test detects the nuclear matrix protein 22 in a urine, aiding in a diagnosis and monitoring bladder cancer. Once you have a bladder cancer, there is a chance of recurrence. So you must be doing the urine examination again and again at the interval to make sure that it doesn't recur. Sensitivity is 67% and specificity is 75%. And this is a simple test in the office lab where you can detect it. BTS stat is a non-invasive urine test, detects the bladder tumor associated antigen. Is a human complement factor H related protein in the urine, aiding in diagnosis and management of the bladder cancer. Sensitivity is 68%, specificity is 74%. And this is the test which can detect the color change, and then you can suspect, and then you can proceed further to find out. Similarly, Eurovision fish test is identifying DNA abnormality in the urine sample. Sensitivity is 79% and specificity is 88%. This is done by the pathologist, and then they can detect by urine examination this test where it will be suspected. Like similarly, immunocyst. It detects, you are looking for a specific substance like mucin and a carcinoembryonic antigen on a cancer cells in the urine sample. Sensitivity is 77% and specificity is 76%. So all this test you do, they done by the pathologist just to suspect that there is a thing. But most important, performing the liquid chromatography mass spectrometry, it predicts 100% bladder cancer in the urine sample. The metabolomic using high performance liquid chromatography mass spectrometry has the potential to become a non-invasive early detection test for the bladder cancer. And then the alteration in the DNA methylation pattern by PSR and direct DNA sequencing was strong predictor of tumor progression. Now you would like to know whether the tumor which you have removed from the bladder, which is superficial, is this going to recur? And this is the test which can tell you that there is a good chance of recurrence, and then you should change it. Now, urine fibronectin, in addition to being the one of the best marker for the diagnosing bladder carcinoma, can be used to determine the presence of residual tumor load. You have done the tumor, but there may be some other place where tumor is under the making. And that time, this test helps you to see that there is a chance that the residual tumor is there, or you have resected the tumor and then some tumor cells are still remaining. This test will tell you that still there is a residual tumor. You have not done the complete job. Please go ahead and do the complete job. So that is the urine test which detect, and this is a very useful in suspecting cancer, especially people who smoke cigarette or bidi. Tobacco smoking is also very popular in our country, and that is it. One second test which you do is ultrasonography, which is very easy. You ask the patient to drink plenty, and then a full bladder sonography you do for the patient who has a blood in the urine, and you see this papillary tumor in the bladder. You can see that, and you can see on the anterior wall also there is a filling defect here, and this is the tumor. And this gives you the idea that it could be tumor. But then there are different type of ultrasound. This is the intracavitary sonography, which you can pass in the bladder through the cystoscope, and this is a probe which you introduce into the cystoscope and pass into the bladder. And then when you do it, it rotates in the bladder, and then there is a tumor in the bladder. You can see this tumor, and then you can see the tumor, number of tumors you have, and then how much it is progressing, whether it is going outside. Because in cystoscopy, you can see the surface, you can't see the depth. And for the depth, you do an intracavitary sonography, and then it will give you. And then you go ahead and do the scopy, and here in the scopy you can see there is a bladder tumor, and then you can diagnose, you can take a tissue and then send for a histopathology to find out. So here, suppose example, you do a cystoscopy, you will see a tumor like this, but you may not see the depth. But intracavitary sonography will tell you the depth. This tumor has gone outside the bladder. It is invasive, and probably he requires, after the biopsy confirmation, you requires a cystectomy. While this tumor is more inside the bladder, and you can see that that is a muscle there, and this is the tumor which is inside. So here you can do the resection and see if you can do it without. So for example, you do a CT scan, and you can see the tumor, and the tumor is gone out. And if you do intracavitary, it confirms that it is gone out, and then you take a biopsy to confirm the type of tumor, and then do it. Very often you see the tumor which is such a large one, and you can do the same probe, you can put into vagina, and then you can see that the tumor is seen in the female, which is very, very large. And so size you can see the number, you can see whether it is infiltrating or not. So if you see the anatomy of the bladder, there is a mucosa, urothelium, then there is a connective tissue, then there is a muscle layer and perivesical fat. If the tumor is less than 1 centimeter and it is restricted to urothelium, it is T1. If it is more than 1 centimeter and it is restricted to mucosa, it is T2. But if it is involving the lamina propria, it is T2. T3 is the one which is involving the muscle. And then T4 is the one which is gone into the perivesical fat, and there is the metastasis outside. Now, every staging of this one the treatment is different. The first you have to diagnose that this is a tumor, and then you have to stage the tumor. The first, let's diagnose by doing the biopsy, and then is the papillary architect is seen here. You can see that papillary architect on a histopathology, and this is a papillary urothelial cancer. There is no doubt about it that there's cancer. Now this is just I'm showing you, but here you take a deep cut and you know that it is involving the lamina propria, so it becomes a T2. And then if it involves the muscle, it becomes a T3. So similarly, so here the papillary carcinoma, you can see pedunculated. You can sometimes see the flat one, but then it is restricted to mucosa. It is you can do the resection and preserve the bladder. But if it is gone into the muscle and then gone outside, then you may have to do the cystectomy. And all this thing is reconfirmed by CT scan or MRI. And here you can see a papillary pedunculated, papillary non-pedunculated tumor. Here is the non-pedunculated, and here is the sessile intramural growth. You can see it is involving the muscle and is growing. And here you can see sometimes there are varieties, multiple tumor. And here you can see this is a superficial tumor too, but this is a tumor which is involving the muscle layer. So sometimes you can have the combination, and that you should be identifying, because your treatment depends upon that. Then you can do the staging of the tumor. It is I will be going and presenting all the different stages. But another thing which has come recently is the MRI. And in an MRI, you can diagnose and stage this tumor by VIRADS. The Vesicle Imaging Reporting and Data System, VIRADS, is used to standardize the acquisition, interpretation, and reporting of the bladder. Because why it is important? Because it is a critical challenge in locally staging the bladder tumor is the differentiation between muscle invasive, where you require to remove the bladder, or a non-muscle invasive cancer, which you can do endoscopically. Now, non-muscle invasive lesion requires a local treatment, while the muscle invasive lesion requires a neoadjuvant therapy followed by a radical cystectomy, eventually adjuvant therapy. So, chemotherapy and cystectomy for a muscle invasive. While non-muscle invasive, you can do it with endoscopy. And this is a Virat system, and Virat 1 is less than 1 centimeter superficial. This is more than 1 centimeter, but still superficial. This is where the lamina propria is involved, and here 4 and 5 is muscle is involved, and this is gone out of the bladder. And now here is Virat 1, 2, 3, 4, 5. I'll give you the example. This is Virat 1. You can see that small tumor, right? And there are different MRI thing, like diffusing wet imaging, then apparent diffusion coefficient, and dynamic contrast examination, and that will give you the confirmation that this is a Virat 1 superficial. This is more than 1 centimeter, and but still the muscle layer is preserved. So this is Virat 2. This is the Virat 3, the sessile growth, but here muscle is probably little bit lamina is involved, and you can see that in a different DEC and DWI, ADC, all that thing gives you the idea, okay, what are the stage of the tumor, because the treatment would be different. But there is no doubt here that the muscle is involved and it is gone out. This is Virat 4 lesion, and this is the one which has been confirmed by all the this thing. This is a Virat 5, where you can see is extra vesicle spread, and it is gone outside, and here you will be requiring a cystectomy to do it. So Virat is very important in staging the tumor. Biopsy is needed to confirming the uh, type of the tumor, and then you can plan your surgery. So if it is a superficial, you can do endoscopic excision. If it is a deep, you may have to do a cystectomy. Now, sometime after superficial, you can do the checking of the we do cystoscopy by checking the bladder. Sometimes you may not see, but that time you use a narrowband imaging, which will give you the idea there is a tumor in making, and you should take a biopsy from there. Now, it is a very superficial tumor, and here you can see that it is a papillary tumor, but superficial. And here I can do a punch biopsy, and then take the mucosa and then take it out. So this will tell me whether this is the inflammatory polyp or this is the papillary tumor. And then if it is a large, not large, but small papillary tumor like this needs a resection. And here I do with the loop, I resect, and then do cut and take out all the tissue which will send for the biopsy. I showed you the biopsy, but what is most important is that the base is taken, because you need to take the muscle to make sure that it is not involved. Otherwise, your treatment will be wrong. So here it will be very important how you take it out, and then pathologist will help you in a diagnosing. Here, so I'm taking all the muscles also. So and then it will be. But nowadays we use laser, because the laser you can take out the whole tumor together. You can divide the muscle and then open up, go up to the muscular level, and a whole tumor is taken out in mass in a one piece, and then so here the muscle is seen, and then you can take it out. And the laser is very hemostatic, so there is no bleeding. You can see it very clearly, and then you can take it out. So now the laser resection via the flexible cystoscope for a recurrent non-muscle invasive bladder cancer, because bladder cancer can recur, and then if it is a superficial, you can reliably excise with the laser. But if suppose it is a muscle invasive, and it is gone out of the muscle into the lymph node, and you want to take it out, you can take out the bladder. But then either you can do ileal conduit, means you take a part of the bowel, put the ureter, and that bowel comes out in the abdomen, or you can make a new bladder, new bladder by way of intestine. And at the same time, you have to do the dissection of the lymph node. If it is positive, you have to give neoadjuvant chemotherapy. And this is a lady who has got a bladder tumor, and here the position is given. You can do either open surgery, you can do a laparoscopic surgery, or you can do a robotic surgery. I'm just showing a small video of a robotic surgery which is done. Now here, first the bladder is dissected, and the ureter is dissected, and the ureter is uh, uh, pulled out, pulled separately, and then removed from the bladder, and then the margin is sent for the histopathology to make sure there is no tumor there, and then you dissect out the bladder. Uh, Separate here in the female from the uterus, in male only from the rectum, and then all the lymph node around it you should take it out. This is blood vessels around the bladder which you take it out, but you can see that this is the bladder and the urethra, and then now bladder is dissected, and now this is the bladder. You are going up to the urethra, and then you are dissecting by the side, making sure that you take the tissue all along the away from the bladder, so all the fat tissue is taken. And here we are going up to the urethra, and this is the bladder, this is the bladder, and this is the urethra, and here we will be tying the bladder, and then dividing the urethra, and then we will take small piece here to make sure there is no tumor there, so that our margin is negative. And then after that, you take the all lymph nodes from it, and these are all lymph nodes by the side. You have to take the lymph node to make sure that if it is sprayed outside, we know about it, we can stage it, we can give a chemotherapy. Now this is the uterus. Now you selected the bowel, small bowel. You can go up to the down, and then you can divide the bowel and make a pouch. And this pouch is like a bladder, and you first unite with the urethra here, and then open up the pouch and make it a small, open up the intestine, and then make a pouch. And here, once you make a pouch, then you take the ureter, and then ureter you anastomosis with this pouch. And here we are anastomosis with the urethra. This is the indigo carmine to make sure that the blood supply is all right. This is the bladder. Is a new bladder is formed, and the ureter now is attached to this new bladder, and on the both side, and DJ stent is kept so that it drains from the kidney, and this is the new bladder. So whole bladder is removed, lymph node is removed, and we formed a new bladder, and from the intestine, and then it has been completed. But most important is the histopathology, because we have to give chemotherapy or not. Usually we give chemotherapy before and after. Now catheter and double J stent is removed after about 25 days, and then patient, if it passes, is all right. Otherwise, he has to do intermittent catheterization by itself. The current standard care of radical cystectomy with a muscle invasive bladder cancer is neoadjuvant chemotherapy. Now we have got a very nice chemotherapy available. We give beforehand, and then we do the surgery, and then after surgery, finding the histopathology, we do the chemotherapy. By doing the cystectomy in time earlier, by doing the meticulous lymph node dissection, we can do that. So therapy for the low risk with a small tumor, we can dissect that tumor like I showed you endoscopically, and then give a mitomycin. The mitomycin will reduce the chance of recurrence. And still, if it recur, and then we may have to give gemcitabine and docetaxel chemotherapy to prevent it. Intermediate state, we after removing, if you find it is involving the lumina propria and it is a high grade, then we give a BCG intravesical to prevent recurrence, or gemcitabine or docetaxel. And then we do the chexoscopy all the time. And for the high risk, as we said, I showed you, we do the cystectomy, and then either we give a gemcitabine or a cisplatinum, or recently we have started using a immunotherapy, which will create. But at the same time, this is a recurrent, chances of recurrence is relapse is there. So you must keep the patient under the observation. And then the results are now good. People are making aware of this. Public awareness program is there regarding the smoking. Government has also prohibited smoking in a public space, and one must remember, if one is smoking, the risk is to the people who are staying with him, because they can do a passive smoking. So the they must be aware that this is the side effect. The more physicians are also aware, there are more than 4,000 papers are published on all this thing, and then the treatment is improving. Previously, we are doing open surgery, then laparoscopic, now robotic surgery, and then the outcome is very good. Now what you require is aggressive screening, especially in smoking people, or they have a papillary tumor. Then after the treatment, they require aggressive screening, rapid diagnosis, accurate treatment planning. Now the treatment is very well established, and the long term result is not. Chemotherapy is coming up now. Immunotherapy is there, which will control the disease. The future is very, very bright for the bladder cancer. But most important, don't smoke. Smoking is harmful. Not only it causes a bladder cancer, it causes a lung cancer, and it causes sometimes a kidney cancer. Thank you very much for kind listening. Is there any question? I'll be happy to take. Thank you.
Thank you so much, sir, for taking out your important time and sharing your knowledge on this topic, sir. I definitely think this session knowledge is going to help all the participants on their practice also, sir. So we have received some questions, sir. With all your permission, shall we take this question one by one?
Yes, please.
The first question is, what is the recommended stepwise approach to evaluating a patient presenting with gross hematuria, sir?
That's one thing is you do the urine examination and the urine cytology, and then you visualize the bladder by asking the patient to hold the urine and do the sonography. You will be able to do it. And if that positive, you do a cystoscopy. All hematuria patients should have a cystoscopy for the bladder tumor, but the cause may be in the kidney. The sonography can detect, or you can do a CT scan. So hematuria is a indication for a total screening of kidney, ureter, and bladder.
Thank you so much, sir, for sharing your expertise on this question, sir. Moving forward, we have another question, sir. What are the histological subtypes of urothelial carcinoma, and how do they affect prognosis, sir?
Now, the most common is this papillary tumor. Now, papillary tumor may be low grade, high grade, and infiltrative. And then second is the squamous cell carcinoma. The squamous cell carcinoma occurs when you have a bladder stone for a long time, and that causes a thing. This is the urachus, and in urachus there could be an adenocarcinoma, which can be present. So most common is papillary tumor. Second is squamous cell carcinoma, and third is in urachal tumor. And sometimes prostatic cancer can invade the bladder, and you can get it.
Thank you so much, sir, for sharing your insight on this question, sir. We will be taking third question, sir. What are the emerging systematic therapies, including immunotherapy and targeted therapy, for the advanced urothelial cancer, sir?
Yeah, the 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 latest is immunotherapy, which is pembro or enfortumab vedotin. The two drugs are available. These are the most effective drug, and it is only in 2023 it is approved by FDA. Pembro is available in India. That by the EV is not available. It is comes from we have to import it from Japan. It is a costly, but it is very effective, and they have a result, a 7-year result from USA and Europe, which shows that even an infiltrative tumor can be controlled with this. But standard is cisplatinum, which is gemcitabine and docetaxel, which is a standard chemotherapy which we give, and that can be given before the surgery and after the surgery that can be given. And then for a non-invasive bladder tumor, a high grade, we give a BCG, and then that is very effective. And but there need to be a regular checkup is necessary. Immediately after a resection of the bladder tumor, we install mitomycin, and that also helps to prevent the recurrence. So chemotherapy is a important part of treatment for the bladder cancer.
Thank you so much, sir, for answering this question, sir. I hope, sir, you have answered the question of the participant, sir. As I can see, sir, there is no more further queries. I hope you have done justice to this topic, and it was really wonderful presentation from your end, sir, with a video, with a proper case study, sir. I hope, sir, it is going to help once again all the audience who are watching this, all the doctors who are out there. And, sir, as there is no more questions, sir, with all your permission, shall we conclude this session for today?
Thank you very much for the opportunity. And I think is a very important topic you have chosen, because public awareness should be there. Smoking causes harm to the
Yes.
bladder and the cancer and the thing. And there are certain dye, aniline dye. So even hair dye, sometimes you be careful. In female, it may result into the bladder cancer.
Great, sir.
Thank you.
Thank you so much for this amazing message, sir. As we know that we, from the Dr. KK Agarwal platform, we are converting this message to all the audience out there. Like smoking is injurious to health. I hope they will be implementing in their life and try to become the healthy population, sir. And thank you so much to you also that you have taken out your important time on this platform, sir. And we would
Thank
like to see you in future also with different topics, sir. Till then, take care of yourselves. Thank you
Thank you.
so much.
Thank you.
Welcome, sir.